Good morning, my dear friends. First of all, I'd like to thank you, Dr. Shanshaksha, for allowing me to share with you this extraordinary event that is MetaSur 2021. My topic is going to be to share with you some comments about the pyrrhus preserving procedure and long-term outcomes, and why is pyrrhus preservation so important. This is my disclosure, but the most important disclosure is what we do at our institution in Madrid, the Hospital Clínico San Carlos. We perform, regarding the bariatric hematology procedure, almost 45% of our patients submitted to a sleeve as a main procedure or a two-step procedure, and then perform a SADIS procedure. We still do 24% of Roux-en-Y gastric bypass, 24%, the same percentage of SADIS procedure, and we are performing many revision procedure at the time goes by around 12%. Well, we have at present time many surgical endoscopic approaches for dealing patients with overweight and some metabolic associated disorder. But within that, some years ago in 2012, Miss Rochlin from New York, he hypothesized that the preservation of the pyloric valve would prevent dumping and is maybe a better physiological alternative for bariatric surgical procedure. And so at this time, we had, and now at present time, we have many surgical options that all of them preserve the pyrrhus. Here you can see the transfibrill or SASI or SAHI, the ilia interposition, and then we have the banding sleeve ring, and then we have some others procedure where we're going to focus on them, like it's going to be preserving the pyrrhus and diverting excluding the duodenum, like the SADIS, the proximal SADIS of the duodenal bypass, of the standard duodenal switch, standard Roux-en-Y duodenal switch. The pyrrhus preservation is going to be important because the pyrrhus is the body's natural flow valve. This keeping the pyrrhus prevents dumping and may also prevent some other nutritional abnormality because, as you can see in the next slide, preserving the pyrrhus, we can improve the absorption of many products, such as proteins, vitamin B12, folic acid, and some ions like calcium and iron. Of course, by preserving the pyrrhus and the part of the stomach, we are preserving also the secretion on some important substances like chloric acid, pepsin, gastrin, and intrinsic factor. So preserving the pyrrhus is going to be important. The other component of these the surgical techniques are the influence of the duodenal exclusion. Of course, there are many action, but overall, the changes in the metabolism of the bile acids regarding the TGR5 receptor and all, the different composition of the remaining coming earlier to the distal bowel is going to be very important regarding the influence of the duodenal exclusion in getting weight loss and in getting the improvement of many metabolic effects. We are going through this agenda. We are going to talk comment some operative technique issues and some weight loss approaches, and the improvement of some comorbidities, and finally to deal with complication of this procedure. Regarding the operative technical issues, here you can see the differences between the BPD, the Roux-en-Y DS, and the SADIS procedure. Regarding gastrectomy, the quantity of the stomach will remove, the duodenal division going to be at the same level in the three procedure, the gastric drainage, performing anastomosis, generally a root duodenal in the duodenal switch and the loop duodenal in the SADIS procedure. We don't do another anastomosis in the SADIS procedure, excuse me. as we do with the duodenal switch and the BPD technique. The common channel is different, it's shorter in the BPD, and it depends of the different approaches going to be variable in the SADIS and the standard Roux-en-Y duodenal switch. Regarding the duodenal ileostomy, we don't do in the BPD, and we do, the ileal anastomosis in the other two procedures. Regarding, the different variants of the SADIS procedure, I would say, one is the SIBS, preconized by Van Cotten and Miss Rorting in US, the differences between this and the standard SADIS procedure that we perform. And the proximal SADIS, I would say, the duodenal bypass is going to be very frequent in the East country, like China, Taiwan, of course, India and Japan. The difference regarding the gastric bougie is going to be narrower in this technique. In our technique, we do a very wider sleeve with a 54 French bougie, and the SIBS or the American approach going to be the bougie between 40 and 42 French. Regarding the length of the bypasses, the interesting going to be 150 through 300 in the proximal SADIS, and going to be depending, because we don't count, case by case this approach. The length of the common channel is going to be between 200 to 250 and 300 at the present time, 300 in the SIBS on the dissection of the SADIS procedure, and going to be, I don't say they're going to be malabsorption, and the absorptive procedure we will comment later on. Of course, the clinical outcome going to be similar to the BPDDS and superior to the Roux-en-Y gastric bypass in this end. The proximal SADIS going to be more similar to regarding the clinical outcome to the Roux-en-Y gastric bypass. Let me share with you, this cartoon, gave to us for Dr. Caetano Marchesini, pointing out, that the most important technical issues regarding the SADIS procedure. We're going to be performing a not very narrow sleeve using a 54 bougie. At the beginning, we start performing the anastomosis 200 from the ileocecal valve, but now we are performing 250, and in some cases, as you will see, 300 from the ileocecal valve, similarly to some Cotton and Miss Rorting approach. I'm talking about the SIBS procedure. Here you can see some cartoon regarding, the way that we are performing our sleeve. If 54 bougie inside, we are very close to the bougie, and in this way we perform a not very narrow sleeve. We dissect the duodenum as far away as we can. We don't divide the right gastric artery. We don't perform reinforcement in this the duodenal division. And then we wing up the distal ileum and perform a tension-free duodeno-ileostomy. Here you can appreciate, you can observe, you can realize how comfortable the surgeon is performing this hands-on duodeno-ileostomy, 2 layers that you will see here. This is the pyrosis over there, and we are performing a 2-layer hands-on anastomosis. It's very comfortable and very convenient for the surgeon to perform this kind of the SADIS procedure. Regarding, the weight loss aspect, here you can see our updated experience 10 years. You have to take into account that we started our procedure in 2007, and now here you have a weight loss 78%, total was 34% at the normalization of the BMI. If we observe, the numbers of the standard duodenal switch, the Roux-en-Y duodenal switch, this paper published by Hess and Hess in 1998, but 100 months after the operation, going to be very stable number regarding the excited weight loss. And if we compare with our experience in the red line, it's very, very similar. It's comparable weight loss regarding the standard Roux-en-Y duodenal switch 10 years after a procedure. We are pending of publishing our updated 10-year result in our patients. And regarding the failure of the SADIS procedures in getting a 50% of safe weight loss, in our experience, it's only 5% of our patients don't get this aim of losing 50% of their exit weight loss. Regarding the controlling or the improving of the comorbidities, mainly type 2 diabetes, SADIS procedure or pylorus preserving and duodenal exclusion procedure, we can get at the end of the day, this is our 5-year result, updated result regarding is 72% of our patients are under remission, no treatment, and hemoglobin A1C less than 6%. If the patient at the beginning had been treated with insulin, 47% were free of their diabetes 5 years after the SADIS procedure. And if the patient at the beginning were with initial oral therapy with anti-diabetic medication, 89% were under remission 5 years after the procedure. But not only the quantity, but also the quality, because we were talking about the importance of maintaining the pylorus and the antropyloric pump, a difference with the Roux-en-Y and other non-pyloric preserving procedure. Here you can see we perform a study measuring in a continuous way for a week the glucose variability in our patient after complete remission. And we compared 12 patients with Roux-en-Y and 12 patients with SADIS. And here you can see how the patient under the SADIS procedure have, a glucose level less than 70. It means hypoglycemic was worse in the Roux-en-Y compared with the SADIS procedure. And the percentage of patients with a normal blood glucose level between 70 and 140 was better in the SADIS procedure compared with the Roux-en-Y. And the percentage of patients with a glucose level higher than 140, it means hyperglycemia was worse in the Roux-en-Y compared with the SADIS procedure. It means that the SADIS procedure maintained, the variability of the procedure in a much more stable way. Regarding the complications, here you can see our revision we published in SOAR in 2018. This is the SADIS complication, anastomotic leak 0.6, anastomotic ulcer, the marginal ulcer 0.1, bile reflux very low 1.1, and there is no stricture because there is no ulcer, because the pylorus is protecting this anastomosis, this hands-on or stapler anastomosis. And here you can see that the damping, if we don't preserve, not only the pylorus, but also the antropyloric pan, is going to be very important to protecting against the dumping of this syndrome that hypoglycemic, hyperinsulinemic status sometimes going to be very difficult to differentiate for the damping syndrome. Here you can see the other important complication. This is the one anastomosis gastric bypass marginal ulcer perforation. Here you can see the extravasation of the barium contrast, and here you can see the perforation of the ulcer. Going to be a very important cons of the one anastomosis gastric bypass. Regarding the bile reflux, it's going to be very important because the pylorus prevents a massive bile reflux into the stomach. But it's happened, we have our antropyloric pump regarding can expel this content into the duodenum. So this preservation of this area, don't dividing the right gastric artery, is going to be very important in terms of getting a physiological duodenogastric reflux. We already studied this with this paper we published recently in SOAR in 2020 with the group of Martin Busin and Marcus Reiser, comparing one anastomosis gastric bypass versus SADIS in patients submitted to failed sleeve procedure. And here you can see regarding the weight loss, be very similar. We compare 42 patients in each arm. Regarding the weight loss, very similar, a little bit better with the SADIS procedure 3 years after the operation. But the most important thing regarding the adverse events, the classification, the Clavin, using the Clavin-Dindo classification. And here you can see that the symptomatic bile reflux was worse, in the one anastomosis gastric bypass. It means non-pyloric preservation procedure, 26% compared with the 5% of the symptomatic barrier flow in the SADI procedure. So it means that the pylorus preservation and the preservation of the antropyloric area is going to be very important. And why going to be these differences? Probably the most important going to be some potential neurohormonal differences between the standard duodenal switch and other non-preserving pyloric approaches. The most important thing, we don't divide it. We don't divide the right gastric artery we are preserving in the SADIS procedure. Going to be here. The right vagus intact is going to be intact. Going to be even though we cut the left, but we prefer the right in this. We can very nicely. The other differences are going to be regarding the exclusion that is going to be very important, and this proximal reflux of food into the proximal duodenum can be solved by the contraction of this antrum that we are preserving. And here you can see, it's a slide, it's a picture for our procedure. This is the right gastric artery, this is the posterior part of the duodenum, and we are not dividing this, we are preserving the innervation, the vagus innervation is the lesser curvature. It's going to be important in terms of avoiding having, excuse me, a very important biliary reflux, ilioduodenogastric reflux. We can maintain this area are going to be, in our opinion, very important in getting this success. So there are other, non-pyloric preservation, like this is the SADIS compared with the one anastomosis gastric bypass and the SAHI and the SASI. So what is the problem regarding non-preserving this area and non-divided duodenum after the period, non-preservation of the period? Of course, there are some, this procedure have duodenal occlusion, but not pyloric preservation. Are going to be a very important technical and physiological point. All those techniques are feasible, but of course, if we don't preserve the pyro, we can induce the Stumpen syndrome, as we already said. We can induce some of those hypoglycemic, hyperinsulinemic status, and we can allow the biliary reflux in the gastric cavity. The controversy of on increasing of facilitating the appearance of the gastric cancer, but for sure there is no doubt that the marginal ulcer, anastomotic stricture, a bile reflux is going to be very important. And the main reason, because I think many teams or many groups don't do that, is the fear about the duodenal dissection. And in our opinion, it's going to be a problem because the learning curve is going to be very nicely managed. In this way, at the end of the day, the patient submitted to preserving pyloric approaches and duodenal exclusion procedure, you want to increase in quality of life because, it's going to be very important. We demonstrated in long-term paper recently published by some teams. So I'd like to thank you all very much for your kind attention. I hope, the MetaShart 2021 going to be a big success. I congratulate Dr. Shansha for this initiative and for allowing me to deal with this issue. So I think, we have to stop recording now.